Good afternoon and welcome to this month's Research Matters. I am Erica Salzik, the Department Administrator for UT Southwestern's Human Research Protection Program, and I will be one of the moderators for today's session. Before we jump into the presentations, here are some general housekeeping items. If you have any questions for our presenters, please type them in the Q&A. One of the moderators will respond to you during the session, or we will address it at the end of the presentation. This session is recorded and will be available immediately after the conclusion of the live session by clicking on the Microsoft Teams live link in the Outlook appointment. We will send the slides and handouts out via the listserv. We will also post the slides and any handouts on HRPP's Research Matters website, which can be found under the Training and Resources page. I would also like to point out that the links for all of fiscal year 22 session recordings are now available on this page as well. We do provide a certificate of attendance for those who have logged in using a valid email address. If you do not receive one via email, but should have, please send an email to hrpp@utsouthwestern.edu to request a certificate. And finally, we want to hear from you. We're interested to know what topics you would like us to cover during these sessions, and this will help us with the FY23 agenda. We are also interested to know how our office is doing, so please take a few minutes to complete the survey to provide feedback. For your convenience, I've provided a QR code that will allow you to scan and complete the survey from your phone, and I will also be dropping the link for the survey in the Q&A in just a moment. And here's today's agenda. So we are going to begin with a presentation from the Regulatory Support Office, presented by Eriko Iwatate and Rasija Nambiar. And they are going to continue with frequently asked questions pertaining to results reporting and provide updates on ct.gov. And then we will have Eric Solis continue with the second part of our vulnerable population series. Eric is going to be focusing on pregnant women, neonates, and fetuses as human subjects. So now I'm going to turn it over to Eriko.
Thanks so much, Erica. Good afternoon, everyone. I'm Eriko from Regulatory Support Office. I work with Rasija Nambiar to support clinicaltrial.gov reporting. As Erica says, so we want to continue on Q&A series on ct.gov. But before that, I want to give you a quick reminder of consent form posting requirement in clinicaltrial.gov. So Office for Human Research Protection at HHS came to give talk during last month's ct.gov task force meeting. So she came to clarify some of the confusion regarding new informed consent form posting requirement in revised common rule 45 CFR 46116H. So what is informed consent form posting requirement? So the revised common rule requires that for any clinical trial conducted or supported by a common rule department or agency, one consent form must be posted on a publicly available federal website within a specific time frame. So important point is the consent form must have been used in enrolling participants in order to satisfy this new provision. And please do not post signed consent. So now, which study needs to post a consent form? So this requirements does not apply to all studies. It actually applies to small portion of study what IRB oversees. So this requirement applies to a clinical trial that meet following criteria. So if it applies to HHS funded, so NIH funded clinical trial, where our PI is the grant awardee or UT Southwestern is the main site for NIH funded multi-center clinical trial, which was approved on or after January 21st, 2019. So if applies to all, then you are required to post one consent form that have been used in enrolling participants. So now what is the timeline? So regulation requires consent form posting after the clinical trial has closed to recruitment and no later than 60 days after the last study visit by any subject. So while consent form could be posted before a clinical trial closes to recruitment, but it does not satisfy 45 CFR 46. So posting must be occur after closing recruitment. So one of the confusion that was clarified during the meeting was that what is considered the last study visit by any subject. So visits occur only because of the research project, so not because of the clinical care. So last study visit also does not have to be in-person visit. So it may be like maybe online survey or phone call, so those count. So with respect to multi-site study, OHRP considers that the last study visit by any subject refers to the last study visit that occur at any of the sites. So not to the last study visit that occur at the particular site. So now, where do we post informed consent form? So at this time, two publicly available federal websites that will satisfy the consent form posting requirement, so as required by the revised common law. So one of which is clinicaltrial.gov. So there's the other one is actually regulation.gov. So you can post it using a docket folder, but we recommend posting consent form in ct.gov so that we can assist you with posting consent form. And we also send a reminder email to the study team to stay in compliance with this new posting requirement. So, so once again, the 60 days clock starts when study is close to enrollment, close to recruitment. So our office will send you a reminder before due date. But in order for us to send reminder in a timely manner, study team must maintain accurate study status documented in the EIRB. So when study is permanently close to enrollment, don't wait for next CR or annual update to report study status change. Submit study status change modification to the IRB. So in modification smart form item 1.1, so there's an option for study status change for the type of modification. So when you select that, it will opens up a new subsection where you can specify what procedure remain on the study. So we get EIRB report on the study status change. So we can send a reminder email to post informed consent form in ct.gov. So we use also same report, so same data dump to send a reminder email for results reporting as well. So once again, please don't forget to submit a modification when study status change. So if you want to learn more about it, please visit HHS website. So OHRP recently issued guidance and instruction on this posting requirement. So these are updates from me. So now I'm going to pass over to Rashida.
Thank you, Eriko. Good afternoon, everyone. I'm Rasija Nambiar, and I will continue with the Q&A series. And today's topic is results reporting. But before I start, I would like to give a quick overview on results reporting. As you all know, results are required to be reported within 12 months of the primary completion date, which is the date you collect the last patient, last visit data for the primary outcome measures for FDA-regulated applicable clinical trials and NIH-funded clinical trials. Consequences of non-compliance include civil money penalties and loss of funding. There is one caveat for NCI-supported trial. You have an option to publish trial results in a peer-reviewed scientific journal within 12 months of trial primary completion date instead of reporting results in ct.gov. And with that, I'll now go over the Q&A part. One of the most frequently asked questions during results reporting is, what is aggregated data? For results, remember, you are required to enter aggregated data of each outcome per arm in tabular format within the ct.gov system. So aggregated data is summary data. Think about Table 1 and Table 2 of the manuscript. Table 1 is typically a sample description at baseline, and Table 2 is typically sample description by arm. For results reporting in ct.gov, you need to manually enter those summary data per arm in ct.gov. You cannot upload the Table 1 of the manuscript. There is no upload or auto-populate option for results reporting. Here is a screen capture of results reporting section of ct.gov. I'm not going too much into detail, but there are two types of data that can be included in the outcome measures and statistical analysis module. One is discrete data, and the other one is continuous data. These data are required to be reported or summarized by the measure type and measure of dispersion or precision used. The measure type data element represents the method used to summarize the outcome data. The measure of dispersion or precision data element represents a measure of the spread of the data. Discrete data are summarized with a measure type of count, for which the measure of dispersion or precision data element is not relevant. And for this, not applicable is automatically selected as the measure of dispersion or precision, as seen in the screenshot here. If number is chosen as a measure type, one of the confidence intervals or not applicable can be selected as an option as the measure of precision or dispersion as appropriate. Continuous data are summarized with a measure type of central tendency, for example, mean, median, geometric mean, etc., and an appropriate measure of dispersion or precision, for example, standard deviation, full range, confidence interval, etc., used to aggregate the data. These are required information if not reported in Table 1 or Table 2 of the manuscript, which the PI asks you to enter on their behalf. So at that time, you would need to consult with the PI or biostatistician to calculate appropriate measure of dispersion for each outcome. Next question is, do I need to submit statistical test results? So the answer is, it is optional for most part. Statistical result may be required if it is pre-specified in the protocol as primary or secondary outcome measures. Typical example including MTD, that is maximum tolerated dose for phase 1 trials, and measure of association such as odds ratio or risk ratio, hazards ratio, and inferential statistics such as mean difference. One thing to keep in mind that typically these statistical test results are not per arm data. It is the combined data of both arms, such as odds ratio or inferential statistics, which is calculated between or across arms. Therefore, it is It cannot be reported per arm. So what would you do since ct.gov requires outcome to be reported per arm? So these statistical reports should be reported in the statistical analysis section attached to the outcome measure section using the add statistical analysis link. Alternative option is tweaking the statistical results outcome into quantifiable outcome measure that can be reported per arm in a tabulated manner for the number of subjects analyzed. For example, instead of reporting maximum tolerated dose, report number of participants with dose limiting toxicity. And perhaps use statistical analysis section to report the maximum tolerated dose. So in this way, you can still report the outcome per arm. Now, another related following question is, will posting clinical trial results on ct.gov be considered as prior publication? The answer is no. Since you are not reporting the study results, but only the aggregated data is reported in tabular format. And the journal publication policy has made it clear that it will not consider summary results data posted in tabular format required by ct.gov to be prior publication for the purposes of manuscript consideration. In order to confirm, you can also reach out to the journal before submitting your summary results to ct.gov. And please note that ICMJ clinical trial registration policy requires prospective registration of all interventional clinical studies, but it does not require results reporting. The other frequent question is, can I get an extension for results reporting? This topic is often discussed during the task force meetings that we attend. And in fact, even last week, the Senior Regulatory Counsel in the Office of Clinical Policy at the FDA came to talk about it. I want to highlight some important points from his presentation that would help answer this question. The extension may be permitted if request is submitted prior to the results reporting due date, that is the day before, with a valid reason. The responsible party can submit the extension request in clinicaltrials.gov protocol registration and results system, that is a PRS system, as shown here. The regulation permits a responsible party to request an extension of the deadline for submitting clinical trials results information for good cause. For example, natural disasters, unforeseen situations, etc. And the extension request must include a description of the reasons that the responsible party believes constitutes good cause to justify an extension, and an estimated date on which the results information will be submitted, with sufficient details to allow for evaluation of the request. The NIH director is the one who provides the decision to grant or deny the extension request electronically. If the extension request is granted, the responsible party must submit the clinical trial results information not later than the date of the deadline specified in the electronic response. This is a real example of unsuccessful extension request that was submitted by the UT Southwestern PI to the NIH director. PI requested extension because sponsor requested to the PI to hold off on the results reporting, but NIH responded stating that information provided did not appear sufficient to evaluate whether there is good cause for an extension. I must say that probability of getting an extension request approved is pretty slim. Now, this is an example that the UW School of Medicine and Public Health used to obtain a successful extension last year from NIH. In this example, the reason for requesting extension was COVID-19 and was thus granted by the NIH director. This is the last question for today's session, but one of the most frequently asked by study teams. Study was terminated prematurely, or study was closed before meeting study endpoint. Do I need to report the results? There are many reasons for early termination, maybe due to recommendations from the data monitoring committee or safety concerns. Maybe the investigator observed early effect or futility. Maybe it's terminated based on risk or benefit assessment during interim analysis. So the results reporting is required for terminated study, and it depends on the overall recruitment status and whether or not the data were collected for the purpose of the study. For those studies that are terminated prematurely, but data were collected, then results reporting of available data are required, even just the demographics. Whereas those studies where it's withdrawn before stating the enrollment, no results are required to be reported because there is no reportable data. Here are specific scenarios and recommended action when reporting results in ct.gov for terminated studies. And by this, I'm concluding my slides on the Q&A for results reporting. Thank you everyone for listening to me, and I'll now pass it over to Eriko.
Thanks, Rosija. So in the interest of time, I would like to highlight just a few points regarding metrics. So last month, we were able to maintain 100% compliance according to Public FEDA non-compliance website. And here's the overall real-time compliance for all UT Southwestern record. Again, overall, we are doing pretty good. We had 0 FEDA problem records last month, a little bump on non-FEDA problems, but we were able to resolve. And this is sponsor investigator support metrics for May for your reference. So starting next fiscal year, we hope to present these metrics in timetable, like one for ct.gov, so we can show the trend of sponsor investigators activity, as well as number of IND, IDE, and expanded acts EAP held by UT Southwestern investigator. Also, landscape analysis is almost complete, so stay tuned for those data. And I will end with the usual slide. Next slide. And here's a selected resource for ct.gov. And contact and link to consultation for sponsor investigator, IND, IDE, EAP related questions. And selected resource for that. So this concludes our presentation. Thank you so much for your attention. I will turn over to Eric.
While Eric gets his slides up, I just want to thank Eriko and Rosija for your presentation. If you have any questions, please do put them in the Q&A.
Sorry, everyone, I need to find my monitor. Teams is so fun when you want to share.
Yes.
Okay, let's try this again.
Yes.
How's that? Okay.
That looks great.
Perfect. All right, well, welcome and thank you for attending the June 2020 Research Matters. I'm Eric Solis, IRB Operations Program Manager, and I collaborated with Kelechi Echendu, Senior Regulatory Analyst, on this presentation. Today, we will continue the conversation on vulnerable populations. Okay. I will cover regulatory additional protections for when pregnant women, fetuses, and neonates are included in research. We will also briefly cover research involving after delivery, the placenta, dead fetus, or fetal material. Before I begin, I would like to make 3 points. Number 1, since the new common rule was implemented, pregnant women are no longer considered a vulnerable population. Number 2, the neonates referenced here and under regulations are those of uncertain viability and non-viable neonates. This is not to be confused with newborns that are neonates that are born where viability is not being determined. When newborns are involved in research, the regulations that cover the additional protections for them are found under Subpart D, as they are considered children, and that was covered during last month's Research Matters. And finally, number 3, as you can see here, this last bullet, FDA regulations do not contain regulations similar to Subpart B under 45 CFR 46. However, the FDA recommends that these requirements must be satisfied for FDA regulated research. So let's cover some definitions. Pregnancy. This encompasses the period from implantation until delivery. A woman shall be assumed to be pregnant if she exhibits any of the pertinent presumptive signs of pregnancy, such as missed menses, until the results of the pregnancy test are negative or until delivery. The fetus is the product of conception from implantation until delivery. A neonate is a newborn infant. Viable, as it pertains to a neonate, means being able to survive after delivery, given the benefit of available medical therapy to the point of independently maintaining heartbeat and respiration as determined by a physician who is not engaged in the research. And finally, non-viable neonate is a neonate, although alive after delivery, is not capable of surviving to the point of sustaining life independently, even with the support of available medical therapy, as determined by a physician who is not engaged in the research. So while the new common rule does not consider pregnant women vulnerable, they remain to be a protected population. As you may already know, research with pregnant women is very important, and this research must be conducted responsibly. In addition to the pregnant woman, the implication for the potential offspring requires additional specifications for such research to proceed. According to the Task Force on Research Specific to Pregnant Women and Lactating Women, pregnant women are often face serious illness ranging from immune disorders to infectious disease to cancer and need access to effective, safe, and appropriately dosed therapeutics. Without pregnancy-specific research, decisions about therapeutic choice and dosing are based on assumption, evidence, and at times based on conventional care. Gaps in evidence lead to uncertainty with using medications that are safe and critical to preventing and managing disease and/or conditions occurring during pregnancy that in turn result in leaving the pregnant woman and her child susceptible to harm. Not having enough safety and effectiveness data on approved drugs for pregnant women results in no treatment of pregnant women. The following slides will focus on 3 components of Subpart B: preliminary evidence, allowable research-related risk, and additional consent. One of the first requirements of Subpart B surrounds preliminary evidence to inform judgments of potential research-related risks to the fetus or pregnant woman. According to 45 CFR 46204A, where scientifically appropriate, preclinical studies, including studies on pregnant animals, and clinical studies, including studies on non-pregnant women, have been conducted and provide data for assessing potential risks to pregnant women and fetuses. So what does where scientifically appropriate mean? According to the FDA, there may be useful real-world data from safety databases about the use of therapeutics in non-pregnant women, observational reports on use during pregnancy, or data from unintended exposures of pregnant women, in the context of research that can serve the function of providing adequate preliminary evidence in the absence of preclinical studies involving animals or prospective studies involving non-pregnant women. The second component of subpart B is for allowable research-related risk, and it is divided into risk involving prospective direct benefit and trials involving no prospective direct benefit. Subpart B is permissive of inclusion in research for trials offering the prospect of direct benefit to the pregnant woman, fetus, or both. Regulations that cover allowable research-related risk pertain to the risk to the fetus caused solely by interventions or procedures that hold out the prospect of direct benefit for the woman or the fetus, or if there is no such prospect of benefit. The risk to the fetus is not greater than minimal, and the purpose of the research is the development of important biomedical knowledge, which cannot be obtained by any other means. And any risk is the least possible for achieving the objectives of the research. Subpart B is silent about whether the prospect of direct benefit to the pregnant woman can justify an increment of research risk to the fetus. The prospect of benefit is described as a category of potential benefit to either the woman or the fetus, where the standard indicates that risks should be justified by benefits without specifics to either the woman or fetus or future child. As you may imagine, research involving pregnant women and neonates results in difficult cases for the IRB due to how benefits and risks are not always aligned between the mother and the fetus or the future child. I would like to add that this is not common. It is not common to see research involving pregnant women, fetuses, and or neonates due to the potential risks posed to these populations. As you are well aware, the most common research that is seen and has been a trend across industry-sponsored research involves data collection for the pregnant partners of male subjects, as well as pregnant women who are active study participants in clinical investigations, studying investigational agents. Sponsors want to follow pregnancies and or birth outcomes when research involves their investigational drug or biologic. If it's not common to see research involving pregnant women or fetuses, it is clear to understand why pregnant women or fetuses are not commonly included in clinical investigations, because the risk to benefit ratio would not be favorable. When research proposes no prospect of direct benefit, do you think the research can pose greater than minimal risk to the pregnant woman or the fetus? That's a big no. According to 45 CFR 46102J, the probability and magnitude of anticipated harms with those ordinarily encountered in daily life or during the performance of routine physical or psychological examinations or tests. IRBs sometimes have a difficult time interpreting what minimal risk means when applied to subject populations, specifically to pregnant women and fetuses. The third component of subpart B involves additional consent under 45 CFR 46204 D through G. So sections D through G indicate that if the research holds the prospect of direct benefit to the pregnant woman and fetus, consent must be obtained from the pregnant woman. If the research holds the prospect of direct benefit to the pregnant woman only, consent must be obtained from the pregnant woman. If the research holds out the prospect of direct benefit solely to the fetus, then the consent of the pregnant woman and the father is obtained in accordance with the informed consent provisions, except that the father's consent need not be obtained if he's unavailable to consent because of unavailability, incompetence, or temporary incapacity, or the pregnancy resulted from rape or incest. So what if there is no prospect of direct benefit? Subpart B of this section tells us that if the research holds no prospect of direct benefit to the woman nor the fetus, and the risk to the fetus is not greater than minimal, and the purpose of the research is to develop important biomedical knowledge which cannot be obtained by any other means, the consent is only required from the pregnant woman. This part also tells us that each individual providing consent is fully informed regarding the reasonably foreseeable impact of the research on the fetus or neonate, And finally, for children who are pregnant, assent and permission are obtained in accordance with the provisions of Subpart B, remember that's for children, which outline the additional protections, as I just said, for children. So now let's move to research involving neonates. Under this section of this part, there are three categories of neonates: neonates of uncertain viability, non-viable neonates, and viable neonates. I will cover each of these categories. To approve research involving neonates, the IRB must determine that the research provides the additional protections described in this section of Subpart B, in addition to meeting the regulatory criteria for approval for all human subjects research. To do this, the IRB must find and document that the following conditions are met when neonates of uncertain viability and non-viable neonates are involved in research. Where scientifically appropriate, preclinical studies and clinical studies have been conducted. Each individual providing informed consent is fully informed of the foreseeable impact of the research on the neonate. And individuals engaged in the research will have no part in determining the viability of a neonate. Now, speaking specifically about neonates of uncertain viability, if the viability of the neonate will not be determined in the course of the study, the IRB may approve the study involving neonates only if the research fits into one of the following categories and meets additional considerations. Category 1 tells us that the research holds the prospect of enhancing the probability of survival of the neonate to the point of viability. Any risk to the neonate is the least possible for achieving the objective of enhancing the probability of survival of the neonate to the point of viability. Or Category 2, the research will not result in additional risk to the neonate, and the purpose of the research is the development of important biomedical knowledge, which cannot be obtained by other means. And the additional considerations regarding the individuals providing consent will be fully informed regarding the reasonable foreseeable impact of the research on the neonate, and the individuals conducting the research are prohibited from determining the viability of that neonate. Regarding research involving non-viable neonates after delivery, non-viable neonates may be included in the research if all of the following conditions are met. The individuals conducting the research are prohibited from determining the viability of the neonate. Vital functions of the neonate will not be artificially maintained. The research will not terminate the heartbeat or respiration of the neonate. There will be no added risk to the neonate resulting from the research. And the purpose of the research is the development of important biomedical knowledge that cannot be obtained by other means. With regards to informed consent, when research involves non-viable neonates, consent is obtained from both parents. The regulations under this part dictate that viable neonates, which after delivery that has been determined to be viable, may be included in research according to the requirements of 45 CFR 46 subparts A, which is the basic policy for the protection of human subjects, and subpart D, regulations outlining additional protections for children involved in research. I want to point out that if you propose to conduct research in this space, meaning any research involving neonates of uncertain viability and non-viable neonates, please consult with the HRPP staff prior to your submission. The last portion of the regulations involves use of materials after delivery, which includes the placenta, a deceased fetus, macerated fetal material, or the cells, tissue, or organs excised from a deceased fetus. If information associated with these materials described here are recorded for research purposes in such a manner that the living individual can be identified, Those individuals are research subjects, and all applicable regulations apply. So with regard to your IRB submission, Form O is used for research, is used for when research involves pregnant women, human fetuses, and or neonates. The form outlines specific regulatory categories for each of these populations, where justification for including these populations and the risk to each of these populations must be provided. As you know, this form is typically used to indicate the inclusion of female subjects who become pregnant during participation, where the subject is taken off study drug and is followed for data collection purposes specific to the pregnancy. As a reminder, the HRPP, as previously communicated, do not see pregnant partners as study subjects. Form O1 should be used when the sponsor requests that female partners of male subjects actively taking study drug become pregnant. For the IRB to review and approve this specific population, in addition to Form O1, a consent form for pregnant partners must be submitted in addition to Form C listing this population that outlines an appropriate recruitment and consenting plan. It is not appropriate to obtain the name of the pregnant partner from the male subject. I'm going to repeat that. It is not appropriate to obtain the name of the pregnant partner from the male subject. The male subject should provide the name and contact information of the PI or study team member to the pregnant partner so that the decision to be followed is solely the decision of the pregnant partner. If this is not provided, the IRB will not approve the inclusion of pregnant partners. In addition, if the sponsor will also follow the outcome of the birth of the child, Form K will be needed to be completed. Of course, that was covered in last month's Research Matters. And sorry I went so fast, but this concludes my presentation.
Thank you, Eric. Will you move to the next slide?
Oh, I'm sorry. There we go.
There we go. So we just want to give you guys an opportunity to submit any questions you have for Eric or anyone else on our team. And while we wait for those to come through, we just want to take a moment to remind you of our survey. So if you could just spend a few minutes to complete the questions, we will use the information to improve the content of these sessions and how we present them. And we will also be able to see what areas we need to work on in the office and what areas we are excelling in. So just give it just a few more moments because I do know that was a short session. So we'll probably give you back a few more, about 15 minutes of your day. And I'm not seeing anything come through. But we'll still be hanging around for a few more minutes if you would like to add anything after we hang up. But I want to thank you all and thank our presenters. Oh, actually, we do have a question. Okay. So, Eric, are you able to restate Form O and Form O1 what their uses are? You may need to go back to those slides. You're on mute. Eric, you're still on mute.
Okay, fine. I had to unshare. Sorry, it wouldn't let me unmute myself. So let me share again.
Okay.
Okay, let me back up. Right, so Form O is not just only for research involving pregnant women, but it's also for pregnant women or fetuses. And I believe it also is for neonates. But what I mentioned is for whenever you have, I guess Form O is used for any female subject who's participating in a study. and becomes pregnant while on study, and the sponsor wants to follow that individual, that's what this form is used for, to describe that.
Okay.
Form 01 is specifically for the female pregnant partners of male subjects who are participating in the study. And in the same fashion, that form will be used when a sponsor wants to follow the pregnant partner of that male subject who is actively taking study drug.
Okay, thank you. And I don't see any other questions, but like I said, if you do need to ask another question, we'll be hanging around. I'm going to give you guys back 15 minutes of your time. Thank you to our presenters. The next Research Matters session is scheduled on July 19th. So have a great rest of your week. Thank you all so much.